All right, welcome back, everyone. Thank you for joining us. Shaun and Bo here today. This time we're talking about femoroacetabular impingement, FAI. Bo, this is a big one because it's such a commonly presenting problem now, right? Like we see this everywhere.
Yeah, it's a really interesting one. And I think the understanding of it's really improving. So let's firstly talk about what it is. So femoroacetabular impingement, we get a bony change either at the acetabulum. So we can have acetabular overcoverage or a deeper acetabulum, or we can have a bony abnormality or bony growth at the head neck junction. So where the acetabular head is, where it sort of attaches to the neck, there can be a bony growth that makes the femoral head no longer spherical. Yep. So we go from a spherical head to more of an egg-shaped head, and that would be called a cam morphology. So cam morphology is a bony change on the head-neck junction, versus you can have a pincer morphology where you can have a bony growth or an overcoverage of the acetabulum on the femoral head. Now, typically the symptoms are aggravated going into hip flexion, adduction, and internal rotation, yep. Which is why it's much more common in the athletic population. Think of a soccer player, a football player, going into repeated hip flexion, hip flexion, rotation, adduction, that can create these bony changes. And typically it will occur during development, during adolescence, when the epiphyseal line hasn't fully developed. So you get this bony change at the growth plate of the head neck junction. So it happens quite early on in development. So symptoms may come on early or late in their teenage years, early 20s. And it's typically quite a debilitating condition because it can progress to other conditions of the hip.
Yeah, and this is one of the frustrating things about it too, right? Because if we're getting these changes happening in the early stages of life, you'd expect to see most people with FAI symptoms around that age, but often it's later. Like a lot of the clients that I've had that have had it are in their 40s or 50s or 60s, and the symptoms come on. And if we look at the genesis of that type of presentation, and we say, well, it's happening usually in the earlier years when they're going through that growth and development, those early stages, then why is it taking 2 or 3 decades for those symptoms to come out? And then that's when it gets tricky, because if we just look at that bony morphology of the cam or the pincer type morphology, or the combined one, because that's another one where you can have them both, there's this other category of contributing factors that go beyond the bony changes. So you could have somebody that's had those bony changes since, say, they were 20, and they've been there for 3 or 4 decades, and then they get the symptoms in their 50s, for example. And then, well, what happened? Like, why now? What happened? And typically it's going to be some kind of external factors, right? So the activities they're doing, or the lack of the activities that they might be doing, the things that they've been doing for 3 decades that kept it at bay, they've stopped. And without that muscular control or whatever it might be as a positive input, they discover these symptoms. I use this term of like functional FAI, which I don't know if I created that or somebody else has, but it just seems to make sense describing. So rather than just having a true bony cause, you've got these other functional factors that contribute to the presentation happening now. And I think a lot of the time, if you can address those, they can go back to zero again. They might still have the bony changes, but for all intents and purposes, they don't have a problem because they've got no symptoms.
Yeah, and there's a couple of things there. So, if someone does have an onset of symptoms later in life, well, they may have had that morphological change their entire life and been completely asymptomatic. In fact, that's actually quite common. But then they may have started to do a particular exercise or activity that started to provoke those symptoms. Or when you look at those morphological changes, we think, well, why did it start to get symptomatic? Because if we start to move into a position where that cam morphology starts to butt up against the acetabular rim, well, the labrum extends out over the acetabular rim slightly. So think of it sort of like if you've got carpet on the floor and you've got that small crease, and the more that you kick over that crease of carpet, it starts to peel up. So that's similar to what happens with a labral tear caused by a femoroacetabular impingement. Now, the labrum, the acetabular labrum, is actually innervated by the obturator nerve. And the labrum provides more of a synovial seal, because the articular cartilage is avascular, so it relies on the joint's synovium to provide it with nutrients. So what I'm getting at here is, if we have a labral tear that may have developed over years, where we've got now changes to the labrum, now we've got a reduced synovial seal, so you get reduced nutrients to that articular cartilage, which can lead to an earlier onset of osteoarthritis. So potentially those symptoms could come from the osteoarthritis, but it was brought about from a femoroacetabular impingement, and it's just gradually developed over the years. So that's an interesting one. And then the other point there, Shaun, of that functional FAI, well, I think that's really an important factor to consider as well, as how is that person spending most of their time? We know that the symptoms are often much worse in a seated position, or any hip flexion based position that, could be squatting, could be sitting for extended periods of time, sitting in low chairs that will give the patient that deep seated ache. But was it brought about due to changes more distally as well? So you can have those proximal factors, excessive anterior tilt, sitting in low chairs that bring that femoral head-neck junction closer to the acetabular rim. Or let's say someone has limited dorsiflexion or subtalar eversion. So when they go into a squat, they're not quite being able to achieve adequate dorsiflexion through the ankle. So they're going to have a compensatory mechanism where they'll probably try to shift their weight, which could lead to more impingement with that hip moving into internal rotation. If they've got more subtalar eversion, again, that can drive the hip into internal rotation. So there's certainly some intrinsic or internal factors to consider what's happening within the joint, but also those extrinsic factors as well, foot position, available range in the distal joints as well.
Yeah, and this is why it's so important when a patient presents to you with an X-ray or some imaging findings that suggest that there's some bony changes happening in the hip, and their GP or whoever it might be that's seen them as diagnosed FAI, and they've gone, okay, well, you've got bony encroachment, bone on bone, that old phrase that we hear so often, bone on bone or bone on labrum, and that's why you've got this pain. Well, that might be part of the picture, but you probably had that bony change there for years, potentially decades. And could it be that ankle injury that you had a couple of months ago has changed the way that you're moving, and now that it's aggravated, the hip, and now you've got those symptoms? And so this is why, a couple of decades, under 2 decades ago, the most common intervention for FAI would have had to have been surgery. They'll go in and they'll shave off that cam lesion or the pincer, and they'll clean up the bone and make it perfect again. And then what happens is you go back and you've got the same other contributing factors, and the symptoms come back, and often that's worse because you've changed the bony landscape in there, and the body will try to right itself in the wrong way. And so we've got to look at all these other factors. Is it the foot and ankle biomechanics? Is there something going on at their knee? Is it actually just their shoes they're wearing? Could be the wrong shoes for the activity they're doing. Is there something happening in the hip and pelvis? Is it a technique that you're applying to your daily activities or the sport that you're playing? Is it that you just lived through a pandemic, and rather than getting up and walking to the train station every day and having that hip extension movement that you get through that activity, or riding your bike to work, whatever it might be, is you just get out of bed, walk to your study, plonk yourself down, sit there for 10 hours, then go back to bed at the end of the day? And so there's a lack of activity that's contributed to this potentially. So I don't know, maybe we'll see an influx of FAI over the next coming months as people start to go back to activities and irritate these tissues that have been chronically compressed and become unhealthy over this period of inactivity. Who knows what will happen there?
Yeah, definitely. There's factors that can be variables that we can tweak and change. It's not that, anyone that presents with anterior hip pain needs to run out and get surgery. It's just, not the case. In fact, a lot of the time, conservative management, the outcomes post-surgery are the same, if not better, and more cost-effective. So, when we start to look at back to the morphology and, the positions that we're in combination with load, we might have acetabulum that's more retroverted, so it faces slightly further back, which means that when we go up into hip flexion and adduction, we might get some encroachment at that acetabular rim and the femoral neck much earlier on. So those are people that might stand with a much wider or toed out stance. So my point there is to say that just, that's fine, but it doesn't mean that everyone needs to squat and move in a certain way. If they say, oh, it actually hurts when I squat in that position, okay, let's find a position that you can squat in or sit in that is far more comfortable, because people will have variations in femoral torsion. Okay, so you can have more of an anteverted femoral head and neck or a retroverted femoral head and neck. The same goes for the acetabulum. That can be more forward-facing or more backward-facing. So just having an understanding that people do have different shaped pelvises, that not everyone should squat and move in the same way. And if something's provocative, what's a strategy that we could implement to get them out of symptoms at the same time while we modify their load? So are they doing too much of a particular activity that provokes it? Do we need to look at their seated postures? Do we need to get them out of a seated position for so long? Do we also need to look at those the footwear, as Shaun mentioned, what's happening as far as their foot, their dorsiflexion, their running surfaces, all of those other factors that can help to reduce a patient's overall symptoms.
Yeah. And then of course, there's the patient who just actually does need surgery, which is always unfortunate. There's a percentage of people, and got one patient I can think of in particular, was a very high level competitive trail runner, ultramarathon runner, and he loved cycling as well, but running was his passion. And I got him to the point where he was very symptomatic, and I took him back to being able to run a little, but pretty soon his symptoms came back. Even though we were doing all the right things, he progressed, but he just relapsed. And so we sort of bit the bullet and said, all right, look, what's cycling like for you? I'm thinking that full hip flexion might still be an aggravating factor. And he said, yes, our cycling is actually not too bad. So we kept the treatment going, kept his rehab going. He got to cycling, and he cycled for probably 6, 7, 8 months more, until eventually we got to the point where it too was aggravating his symptoms. And then he did all these other bits and pieces, but eventually ended up under the surgeon's knife, had the surgery, came back from that, and has been able to get back into riding at a fairly competitive level. Hasn't come back to the running, unfortunately, but at least he's got that now. Did all the right things, but at the end of the day, surgery was the right thing for him, because the bony changes didn't just happen in his early days. They actually progressed. He was in his, I think, late 40s, early 50s, and they were continuing to progress over time. We could see those changes through the imaging. It wasn't a moment in time that we noticed it. We saw it progressing, and you get those, right? And it's unfortunate for the patient, but you want to be absolutely sure before you make that call.
That's a great point, because that certainly does, and there is a strong correlation between FAI and osteoarthritis. Patients that present with FAI are 4 times more likely to have early onset osteoarthritis within 5 years. So, when you look at your elite athletic population, it may be something to consider. But then you might have someone who's just a general weekend warrior that presents with symptoms, just when they're training or playing. Well, you got to weigh up, is that right for them? Because remember that FAI is a movement-related pain or pathology. So it's always going to present with your hip flexion, adduction, internal rotation, which is interesting when you start to look at the assessment of it as well. For a true diagnosis of FAI, you need to have the patient's symptoms, clinical signs, and imaging, because looking purely at imaging alone doesn't give enough evidence for FAI without the symptoms and the clinical signs. So when we look at the overall presentation of FAI, We need to have a combination of those things together. And as far as diagnostic testing, your Feder's test in combination with your anterior impingement test. So Feder's test has a really high sensitivity, which means that if it's negative, it gives us a better idea that we could potentially rule out an intra-articular source of pathology. And then you've got your anterior impingement test, which is very similar to the Feder's test, but you just don't go into as much hip flexion. And then you combine that with a prone hip internal rotation. So if you're starting to cluster those tests together, they're all positive, and then you've got the reported signs and symptoms, then it's much more likely that they'll have a diagnosis of FAI.
Yeah, and that's a good thing with our assessment. You've got to really cluster these tests together. And there's no perfect test for anything. Feder's test is a fantastic test. It's very useful as part of the assessment for this condition. But like you said, it's high sensitivity, so you have to be cautious with that. That can be a negative. Exactly. And then conversely, we often look to, you can do this around the wrong way. You can do this sort of both ways. You can get imaging. Someone can come in and say, we can test. It looks like you've got FAI. Let's test for it. And so you do a Feder's test, and it's positive, and you go, well, you probably got FAI. Or is it just a very sensitive test, and coexisting at the same time, just by coincidence, you have these bony morphology changes that just happen to be there for the last 20 years, but could be completely unrelated to the fact that it's a labral tear or a tendinopathy or something else that's going on in there as a result. So, and it can go the other way too. We'll often do all the right orthopedic and physical and subjective and objective testing, and then go and do the imaging as the confirming component. That's useful, but it's only in combination that it's useful. It's not like you check everything and you think it's this. You get your imaging and you go, well, it must be, because imaging is only one other piece of information. It's not the gold standard. It's not the most important part. It's just one part.
Yeah, definitely. Are they responding to conservative management? If they're not responding to conservative management with any injury, really, refer on for further investigation.
Yeah, that's right. And FAI is one of those things I think we're probably going to see more and more, just because of the society that we live in and the levels of inactivity maybe that a lot of us are experiencing. I know that you and I are finding ourselves sitting at these desks more and more every day with the work that we're doing. It's going to be good to get back out on the road and start teaching again. But I always laugh and say that, the old injury that was the most popular injury back in the 80s and probably early 90s was osteitis pubis, OP, which isn't even called that anymore. It's got a new name or multiple new names. Now it's FAI. Everybody wants to have FAI. Well, not wants to have it, but you know what I mean? It's it's a really popular thing, or commonly presenting thing. And I think that we have to look at more than just the bony morphology. We have to look at what are the contributing factors in a society that contribute to this. What are the things that we're doing now that we weren't doing 20 or 30 years ago? Because the human body hasn't evolved that much in the last 100 years that we're seeing new bony changes that weren't probably there 50 years ago or 100 years ago. It's the other factors, right? It's the way that we spend our day. It's the positions we put ourselves in. It's the activities we undertake or don't undertake. They're really the factors that we have the greatest ability to influence as therapists and help that patient move away from their pain.
Yeah, we spend so much time seated now, and then go to the gym, might do some squats, or go out and play footy or whatever it may be. That sustained or repetitive hip flexion type movement that brings on symptoms in that anterosuperior aspect of the hip. That's typically where the patient will feel that deep-seated ache, and they'll do what's called a C sign, so they hold around the hip like that, and that usually tells you that it's going to be a bit more intra-articular. But yeah, as you said, Shaun, our lifestyle's changing a lot. We've got to consider what's happening around the hip and see how we can modify that to modify someone's symptoms.
What about treatment then? So if we in these talks, we don't often get into treatment because it's hard to be very specific and we don't want to be too prescriptive. But as an example, we've got someone who might have presented with some bony changes, on imaging. The symptoms have come on recently because they've changed the activity that they're doing or reduced an activity, and they've got that kind of pinching sensation at the front of the hip, squatting low hurts, pulling the knee towards their chest. Definitely flexion internal rotation obviously is a problem. Where would you start with your treatment for someone like that, without, of course, considering all these other potential contributing factors? What could you do from a treatment point of view?
Yeah, that's a great question. And just thinking three-dimensionally here around the hip, if we look at where that femoral head sits within that acetabulum and the vectors of force from the muscles. So if we look at, say, laterally, you've got the anterior fibers of glute med, glute min, iliopsoas that will pull that femoral head in a sort of an anterior and superior position, sort of in that 3 o'clock, if we thought of the acetabulum as a clock face. Well, if they're getting much more used or stronger, and we're creating that anterior shearing force within the acetabulum that may lead to labral changes as well, well, we think of how do we reverse that? The opposing muscle to that is going to be those deep external rotators. And particularly quadratus femoris is one that will have a medial and inferior pull on the femoral head within the acetabulum. The external hip rotators will have that direct medial force. So similar to the rotator cuff, where we're looking to centralize that femoral head within the acetabulum, provide that more stability, because labral tears, osteoarthritis, intra-articular pathologies tend to be exacerbated by shearing forces. So if we can get that hip stronger and that femoral head more stable and central within the acetabulum, that can be useful. If you think on that same sort of way of thinking, if we've got someone that's in that real anterior tilt, all right, well, that's going to sort of bring that hip into a little bit more flexion anyway, especially in a seated position. So if they're sitting and they're up in this real anterior tilt, we might need to get them just to slump back a little bit, sit into that posterior tilt, because that will change where that bony change at the head neck junction is butting against the anterosuperior acetabular rim. So pelvic position, pelvic on femur, that could be one component to it. Could be strengthening up those deeper external hip rotators. So when you do that, you might want to look at treating or taking some tension out of those anterior muscles, such as psoas, iliacus, pectineus, rec fem, gluteus, anterior fibers of glute med and glute min. So treatment-wise, and then, you can even look at things like joint mobilization techniques, right? If we're creating a posterolateral glide of the femoral head within the acetabulum, again, we're trying to centralize that femoral head within the acetabulum. So there's plenty of techniques, Shaun. I'm sure you could add some more to that as far as exercise.
Like you can approach it from exercise and treatment. I think probably expanding on something you just said about, addressing those soft tissue contributing factors, those anteriorizing muscles, the muscles that pull the femoral head forward in the acetabulum, reducing tone on those is critical. And then obviously the next step is to activate, strengthen the muscles that will posteriorize or pull that femoral head back towards the center of the joint, towards the back of the joint. So your glute max, your posterior fibers, your glute med, those sort of muscles that are really powerful posterior drivers of that femoral head. And so I think the mistake a lot of therapists or exercise therapists might make will be to go straight to the strength work. And this is I guess it's a blanket rule that I often try to apply, and it doesn't work in every situation, but a lot of them it will, which is if you've got tight muscles on one side of a joint and potentially weak muscles on the other, and you go straight to strengthening the weak ones, well, you're fighting against a tight rope. Think of it, two guy ropes on a tent pole. If one's loose and one's tight, don't make the other one tight and hope that will loosen the other one off. Loosen the first one so it's got somewhere to go. And so address those really tight muscles at the front first, I think would be the initial kind of approach. And then over the longer period, you start to activate and strengthen, because if you've got tight psoas, iliacus, TFL, rec fem, all those muscles at the front, they're also contributing to a reciprocal inhibition of those posterior muscles. And so if you go and say, right, I want you to go in the gym and work on your supine bridges and your squats and your step-ups and your lunges to really fire up those glutes, you're fighting against neurological inhibition. potentially. And so reducing the tone so that the nervous system's got an actual chance of firing up those motor units in the posterior drivers, get that femoral head shifting backwards, get a little bit more balance anterior to posterior, and then address those things that aren't probably obvious. You know, if you're getting a personal trainer and they're forcing you to have your toes facing forward when you squat, if they're forcing you to, you know, move in symmetrical patterns and symmetrical ways, then we've got to remember that not every body's symmetrical. Not every human body is symmetrical. You might have one anteverted hip on the right-hand side. You might have one anteriorly rotated pelvic innominate on the left. That's going to change the arthrokinematics and therefore the osteokinematics of the pelvis and legs. So, and that's your average PT is not going to pick that up a lot of the time. You know, a good one will, but the average one won't. So you've really got to look at this in detail to not just address it from a treatment point of view, but how is that person moving and is their movement appropriate for them?
Yeah, Shaun, that's a really good point. You know, when people tend to think you always have to squat symmetrically the same side. Well, what if someone is really symptomatic? Are you going to say, don't squat at all? Don't bend down and pick anything up? That's adding more fear to the movement. You know, that can have a detrimental effect. What if we say, well, what if you put one leg out here or turn that in a different direction and squat? We don't always need to move symmetrically. In fact, we shouldn't always move symmetrically. So if we can get someone to go through a movement with a foot or hip in a different position, get them to repeat it, get them comfortable with that movement, their symptoms settle down, then we slightly change that foot position. So we're progressing them back to getting them back to their goal, which was to squat or to bend down and pick something up, or, you know, be in the garden for a few hours, whatever it may be. So they don't need to move symmetrically. The best movement would be the one that doesn't provoke their symptoms.
It works for them. That's right. And you might think, well, there's 1,000 ways that you can adjust somebody's feet and knees for a squat. Well, maybe don't try to adjust it. Have them stand up and say, I'm just going to put this pen on the floor. Can you pick it up for me? And then watch what they do. And you might notice that, oh, they actually turned that right foot out a little bit and their knee moved out laterally more than the left one. You know, so, okay, well, let's exaggerate that for a second. Come back up. And this time do a squat for me, but I want you to put your foot and knee over there. And does that feel any better or any worse? And they'll go, actually, it was pretty good. I didn't have any pinching that time. Okay, cool. We might have found a strategy for you there. And so often you need to let them move, and you'll just watch, you know, just have them play with some movements, and you watch. They'll usually find the path of least resistance. So you don't have to discover it for them. They'll do it for you. You just got to watch.
Yeah, that's the thing. We're not that fragile.
No.
We can move in different positions under different loads. It's just about conditioning someone to be able to withstand those loads and then progress it. You know, at the end of the day, someone's coming in because they've got a problem with doing an exercise, an activity, whatever it may be. We need to find that strategy to get them to do it. And then just looking at those other modifiable factors, like, are they sitting in a chair that's too low? Could they really sit up a bit higher? Could they get a stand-up workstation? If they spend a lot of time driving, you know, that's another factor in those bucket seats. So just really exploring other factors that may be exacerbating their symptoms can be really quite useful.
Great. Well, that's I guess the tip of the iceberg when it comes to FAI, right? There's so many factors, and we've talked about a lot of things there. But I think probably the most important takeaway for this would be, yeah, there's some bony changes happening a lot of the time. Not always, but a lot of the time when someone presents with FAI symptoms. But to have a true FAI, you need to have some bony changes plus these other things to have a truly diagnosed FAI. And then what does that mean for the person? Does it mean they're going to need surgery? Absolutely not all the time. Sometimes, yes. But there's 1,001 things that you want to try before you send them off to that orthopedic surgeon, get under the knife. And then on the other side of that, of course, is that, you know, the research shows us that if you just do the surgery, but don't do the rehabilitation, don't do the exercise afterwards, then, you know, the chances of them having a successful recovery are very slim. You know, they're not great. So you've got to look at that whole long-term approach and a very holistic approach to it.
Yeah, I completely agree.
Cool. All right, well, we'll leave it there. Thanks, Bo.
Thank you.